I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. Our guest today is Terry Reiser. Welcome, Terry.
Thanks, Dr. Escude. I appreciate it.
So we are coming to you from the Association on Aging with Developmental Disabilities Conference here in St. Charles, just outside of St. Louis, Missouri. Great conference this year, just like it is every year.
Yeah.
You've had record numbers, right?
Yes.
Yeah.
No, we've more attendees than ever.
That's exciting.
Almost 500.
So you're a board member of
I am.
the organization. Tell us a little bit about the organization.
So I became involved with AADD back in 2017. My employer had sent me to attend a conference, and I was AADD is comprised of people who are so passionate about the field of aging with developmental disabilities, and the folks who are involved with the service organization. I think, was it 20, 30 years ago, put on their very first conference. This is an amazing conference. It's such a niche. I've been involved with the American Society on Aging, the Gerontological Society on Aging, but there is nothing like this conference. This is the only conference where you have that intersection of aging and developmental disabilities.
You know, this is sad but true, but many years ago, we didn't have that intersection very much because people weren't living that long. People
Very
with
true.
intellectual and developmental disabilities weren't living that long, and life expectancy has increased significantly due to healthcare and medical care. But then that brings into play things that we all also get to experience as we all get older, like arthritis and dementia and other things as well. And that's really why this conference, I think, is so valuable, because it really helps people to understand what happens and how you can best support people through the process of aging when they have intellectual and developmental disabilities.
Very true.
Yeah.
And, you know, as you say that just strikes a chord. I had an aunt with Down syndrome, and, you know, at birth, her life expectancy was, you know, just 2 to 5 years. And as she aged, her life expectancy increased, and she actually lived into her 60s. You know, and at the time that she was born, that just, you know, that was just inconceivable.
Yep. I experienced the same thing as a physician when I started working at a large residential program for people with intellectual and developmental disabilities. You know, I was taught that people with Down syndrome, for instance, didn't live until, you know, past 30 at that time. And I walked in and there was a 61-year-old gentleman with Down syndrome, and I was like, wow, this is not what I learned. You know, people are definitely living longer.
Right. Unfortunately, they still don't have the life expectancy of people who don't have Down syndrome or other developmental disabilities.
And they're at more risk, Down syndrome in particular, for things like dementia, Alzheimer's in particular. So you mentioned your aunt, and you know there's some key terms we hear when we work in this field, and one of them is Willowbrook.
Yes.
It has a history, and your aunt lived there. Is that right?
She resided in Willowbrook. At least in the 70s. Yeah.
For everybody out there, let's talk about what Willowbrook is or was.
So Willowbrook was a state institution for the developmentally disabled, although they didn't call people that at that time.
They used a different word.
A different word.
The R word, which we don't use anymore.
We don't use that, no. So it was a state institution for people with developmental disabilities, adults and children. It was based in Staten Island, New York, and it really tragic, notorious mistreatment of the adults and the children who resided there. That only became apparent in, I think, the early 70s.
I think so, yeah.
It was the early 70s when Geraldo Rivera, of all people, he was like a good investigative reporter at that time, broke the story. But you know, the stories, and I was reading back because, again, I was very young at the time. I didn't know all of the stories, but you know, they said that they allowed 3 minutes for eating, so they had to choke down their food within a 3-minute period of time. I know with my aunt, we could never really send her back with anything because the staff or other residents would take all of her belongings, including clothes. And horrifically, one of the really awful things was that they were actually experimenting on some of the residents and injecting hepatitis virus into some of them.
Gosh.
It was just awful. I mean, so yeah, it's been closed.
Yeah, that's been closed.
Yeah.
When was it closed? Do you know?
I don't think
either.
it was actually closed fully until at least the 80s, and there may have been some residual people living there, into the early 90s, but definitely in the 80s.
So tell us more about your aunt. What was her life path here?
So Margaret Mary was admitted there at a very early age, and again, I was young,
Sure.
and she was maybe 5 or 6 years older than me. But she was still a child when she was admitted. And I remember my grandmother did not want to admit her, but, the physicians and everybody around said, no, she has to go here.
The best thing you can do is put them in an institution.
So she followed everybody's advice. Now, I had a very large family. My grandmother had 10 children. My mother is the oldest. So we used to go and visit Margaret Mary on, summer afternoons.
How was that?
We never went into the facility ever. They wouldn't let us in. And so we would picnic on the lawn, and we would play ball and, hang out as a very large family. And what I remember was just Margaret Mary screaming and crying uncontrollably every time we left. It was just,
gosh, that's gotta be
it was,
heartbreaking.
even as a child, I was just like so affected by that. It was horrible. So anyway, and again, this is where things get a little bit fuzzy. I don't know if she left Willowbrook as a result of the story breaking,
Right.
or if she was forcibly transferred. But she was transferred to an institution in upstate New York, again, against my entire family's wishes. But at least there, she started engaging in employment activities, and she would do things like she would put the aglets on shoelaces.
Okay.
And fringes on rugs, and she was really proud of that. She loved
Nice.
that she was able to put fringes on the rugs. So
Sounds like it was an improvement.
it was an improvement.
Sure.
And then one of my aunts is a social worker, and she eventually, my grandmother transferred guardianship to my aunt, and my aunt's a very strong advocate, and she got Margaret Mary transferred to a group home on Long Island, closer to where everyone lived. And that's where Margaret Mary lived out the rest of her life. And we saw her frequently, and we would hang out with her.
Did she have the same reaction when you visited
No.
her in the group home, and then after you would
No,
leave?
she loved the group home. She had friends there. She had her belongings. We would give her Christmas presents, and then we would see when she came to visit or stay with us for the weekend, she would still have her belongings. They weren't stolen, so it was a totally different life.
It's a terrible story to have to talk about, but I think it's important that we remember all of that time and where we've come in terms of supports and services for people with intellectual and developmental disabilities. I mean, we still have a ways to go. There are always things that can be better, but there have been a lot of positive improvements, and it made a difference. Those changes that happened made a difference in your aunt's life, and they make a difference in everyone's life. Really, all of us. When we, all of us in society, when we need to treat people as people, right? People first.
Absolutely.
Yeah.
Absolutely.
Yeah. Wow. So you have other roles, other things you do in this field. Tell us a little bit about those.
So I've been in the field of Medicaid and Medicare managed care for 25 plus years. And what we're seeing on the Medicaid side, it's not widespread yet, but we're seeing more state Medicaid agencies integrating the IDD waivers and people with IDD into their Medicaid managed care programs.
Okay, so just to make sure we're all
I know,
on the
I've
same,
used a lot of
same page
healthcare
here.
lingo.
So but it's good to talk about these
Yeah.
things. So managed care is kind of a different way of paying for services,
Right.
Than what we would call fee for service, right? So fee for service is kind of what we're typically used to, where you go to a hospital or a doctor's office, there's a service provided, and then there's a fee that gets paid for that. Managed care is a little bit different, right?
Right.
So managed care, the fee basically is paid a flat or a regular fee, like a PMPM
Right.
per member per month.
Capitation, right?
Yes, is paid to this managed care organization, and then they become responsible for all of the healthcare needs of that person.
Right.
And so I'll let you tell us, are there some positive things in that?
I do think that there are some positive things. So what states are doing is, rather than administering the healthcare program themselves, they're going out to private companies and they're having competitive procurements. So companies that, can say, that can prove best that they can handle and manage the Medicaid contract, get the contracts or awarded the contracts. And there is a lot of incentive within managed care to identify issues and treat them up front.
Preventive
care.
And having people, the healthier they are, the healthier the plan would be.
Right, exactly.
The more successful the plan
financially
would be.
speaking, as well as, there's a lot of reputational damage that if you have poor quality care, that just hits you across your entire business.
Sure.
So it's to everyone's benefit to provide high quality care and to keep people as healthy as possible, from a preventive perspective.
So you mentioned that you're seeing more states that. All right. Well, let me back up. So when managed care was coming into a lot of states, which it's in a lot of states now, but there was. The services for people with intellectual and developmental disabilities were carved out, is what they said. They usually did not include people with IDD. Now we're seeing these plans start to include people with IDD, both for acute care services, meaning hospital visits and doctor visits and things like that, medical visits, but also for the long-term services and supports part of it as well, too. And that's relatively new. How's that going in your view?
I think it's fantastic that health plans are looking at all of the factors that affect a person's health, particularly when you're talking about vulnerable populations like people with IDD or older adults who require those LTSS or long-term services and supports. So you have health plans going out and actively developing relationships with organizations such as AADD in the community, and really working closely with families, doing intensive care management. So providing benefits that are not at all typical, not what you would think of as being a healthcare benefit, but transportation to doctor's appointments.
And that can be a huge barrier. That's one of the social determinants of health, right?
Exactly.
And if you can't get to the doctor's office, you're not going to get good health care.
Right.
You can't access it.
Right.
Yeah.
And then I'm personally also seeing in a lot of what the managed care companies are doing is contracting out with companies. I shouldn't say companies. I'm sorry. That with provider groups that specifically focus on people with intellectual and developmental disabilities, because so few providers really have expertise in that area. So if I can use the name of someone who's here at the conference, Station MD, for example. So it's a telehealth company where all of the physicians who are affiliated, have training and experience, and I believe actually that you train them, right?
We do train them,
yes.
and also have some other exciting projects related to Station MD. We know them well and have had them on the show too, so. And you certainly can talk about them.
Okay, great. Fantastic. I mean, it's really fantastic because when you go out there and you say, okay, how do we keep our population healthy? And there just aren't that many providers who have that expertise. Number one is you go out and you train your own network of providers. And then number two is who's out there that we can include in our network who already has this expertise.
Now, just to be clear, because the word provider means two different things in this field. There are providers of residential supports and services, and then there are healthcare providers. So you're talking more about healthcare providers in that picture.
That's a really good distinction, yes.
And that's something we've talked about on this show as well, is the extreme need to teach all healthcare providers of all levels about how to provide healthcare with people people with intellectual and developmental disabilities. That is a major issue, I think, and a major barrier, and a reason for one of the reasons for health disparities.
Right.
There would be if you came to me, I'm a family physician. If you came to me to have cataract surgery, there would be a major disparity, health disparity for you, because I'm not trained to do that.
Right.
It's not that I don't care. It's not that I'm not interested, but that's not what I do. And I think that's something that really needs to be in every clinician's toolkit of what they can do that they should be able to provide a basic level of competent and compassionate healthcare for people with intellectual and developmental disabilities.
Absolutely, no argument with you there.
Yeah, so you're going out from a managed care standpoint and trying to find clinicians who are trained, or even possibly providing some of that training. It sounds like.
Right,
yeah.
But even more than that, the training needs to extend to people within the managed care company itself, because again, you've got...
I was going to ask you that, actually. It's like, do you feel that managed care companies on a whole or like you said, have the training and expertise to be able to provide these supports and services?
So if they are providing, if they have a clearly defined group of people with intellectual and developmental disabilities in their population, then, yes,
Probably
there's that
so.
impetus to be trained, and probably so. But I know my experience has been that unless it's carved out into managed care, or carved into managed care, it's very difficult to identify people with IDD. There's really there's no markers in your enrollment system where you can say, okay, here's the 20,000 people.
You're exactly right about that. I know a lot of electronic health record systems don't necessarily have a way to document those, and we're seeing changes and improvements in that as well too.
Yeah.
And then there are so many different diagnoses that can relate to an intellectual or developmental diagnosis as well too. So it can be a little bit challenging.
Yeah.
I think I kind of interrupted you a little bit when I jumped in there, but you were talking about the organizations not being able to identify necessarily people with disabilities, and that's a challenge as well.
That's a challenge with data. I think healthcare companies have done an incredible job with data and technology, so maybe it's just a matter of time, but I've had some recent experiences where we said, well, how many people are we serving? And the answer was, well, our best estimate is. So you really, unless you can define the population, how do you target services, and how do you ensure that they're getting access to all of the resources that are available through not only your health plan but through the community?
You mentioned how the managed care organizations kind of focus more so on preventing illness and keeping people healthy. And I'm kind of thinking of a corollary here, and this may be a little bit of a stretch, but managed care organizations can be proactive instead of maybe when you're starting to have a population of people with IDD that you're responsible for, and then start to learn about this field. Maybe there's some education and training, and I'm sure it does happen, but or there should
not
be
as much as you would want.
Okay, so you kind of get where I'm going.
I think there's room for improvement.
A focus
there.
of let's build up our managed care organizations workforce in terms of understanding people with IDD and how to best provide supports and services beforehand. Right. I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. So that leads me into the next little thing we do here, and we're going to twist this here. So I always ask guests to give me what I call 3 and 3. Three tips in 3 minutes that you think can improve the world of supports and services or healthcare or whatever for people with intellectual and developmental disabilities. But for you, I'm going to specifically ask this in a little bit different way. Do you have 3 words of wisdom that you would recommend for managed care organizations in general that are getting into this field that can improve, the services that they provide?
To managed care?
To managed care organizations.
Okay.
Yeah.
Number 1 is improve your data collection and your understanding of who, because I can tell you that probably every managed care organization, even if they don't have a carve-in IDD contract, they are likely to serve people with IDD.
Right. They're still serving people with IDD. They just don't necessarily, it's not a class or a group.
It's not a class or a
particular.
group. Yeah. And if you're going to do population health, you need to understand your population. So number 1 is nail that. That's really got to be nailed. Number 2 is educate folks within your organization. We're working with so many different people with complex, conditions, and we need to have an understanding of that entire universe of populations. And I think people with IDD have really been kind of left behind. So we really need to focus on getting a good understanding and bringing people into the organization who have that expertise, so that they can kind of help the people around them, and implement the types of processes and policies and benefits that will support that population. And then number 3 is be an integral part of the community and start working with all of the organizations that support people with IDD. So
yeah, those are 3 great points, and I love the point about the training and education, because that's my passion really, is to provide training and education to people who work in this field. And what's kind of exciting is people are reaching out to us and our organization now to help provide training for managed care organizations. So they're starting to look at these things even more. So great words of wisdom for everyone out there. And Terry, first, thank you for taking the time to be on the show. This is really cool. This is really informative.
This is a lot of fun.
Yeah.
Thanks.
More importantly, thank you for the work that you do in this field. It reaches so many lives and people that we probably will never know when we work in this field. And there's a lot of, I think, personal satisfaction that comes from working in this field. So, that's a plug for people out there. If you're looking for a career or an opportunity to do something that makes a difference in people's lives, consider working in the field of healthcare or supports and services for people with intellectual and developmental disabilities. Thank you, Terry.
Thank you.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.